Yes.
Professor Hann, I wanted to ask you a little more now about non-A, non-B hepatitis. Your evidence in your statement is to the effect that non-A, non-B was regarded as no more than a minor illness at the time you started at York Hill. Now, it's clear from the evidence you've given so far that hepatitis B was regarded as a very serious condition indeed. What was the basis for your belief or understanding or assumption that non-A, non-B hepatitis was minor?
Right. I didn't put it very well there, to be honest with you. What had happened in the latter part of 1979 and 1980 was that hepatitis, non-A, non-B hepatitis, had come much more into the forefront of publications, etc. But unfortunately, it brings up a problem that I think we struggled with, and I, believe that I failed to a certain extent to communicate adequately, and that is the level of uncertainty associated with certain problems. The point about it is that we knew by this stage, and I'm sure you've had evidence of this, that probably your first dose of concentrate was enough to cause, to give you a dose of hepatitis, and latterly we knew that was hepatitis C from 1989 onwards. What that did not tell you, and what led to all the uncertainty, was what the prevalence of persistent and infection and liver damage was. Subsequently, we knew that it was eradicated endogenously by the patient themselves in between 25 and 40% of cases. And to give you an idea of the uncertainty of what clinical problems would ensue, during my time at Great Ormond Street between 1988 and 2006, during which time some of the patients would be in their late 20s and being followed up jointly, just one patient required treatment for hepatitis C hepatopathy. We also knew at a later stage, probably in 1985, from the studies of Pierre Minucci and Lou Aladort in over 100 patients receiving liver biopsies, that the frequency of liver diseases in concentrate patients was no greater than in patients treated principally with cryo. And at this time, they therefore said, and this was the mantra, if you like, there's no indication to alter current therapy because of concern over transfusion transmitted infection from plasma production. And that finding, clinically anyway, was reviewed again in 2003 by Minucci, who confirmed those findings. Basically, the problems we had were of uncertainty. There was no diagnosis. The mantra was, if you found that the liver transaminases function tests were more than doubled for 6 months, then you could think that that might be non-A, non-B hepatitis. But of course, that turned out to be a completely insensitive test. Many patients were affected despite not having those findings. And I don't actually remember any patient who would have fulfilled that criteria. So we couldn't say you had non-A, non-B hepatitis even. It was probably multifactorial and Purcell, and I was trained to a certain extent by Dame Sheila Sherlock, who was the guru of hepatology and viral hepatology. And basically they said, don't use the term hepatitis anything because we don't know what it is. It's probably multifactorial. It could be due to a rag bag or multiple viruses. We knew subsequently that the peaking of incidence occurred around about 1968, that it fell to a very low level by 1990 when the virus was actually, hepatitis C was actually found. We knew, and it was my experience, that very few children had symptomatic episodes of hepatitis with non-A, non-B. So, both diagnosis, prevalence, persistence of infection were very uncertain. And then, we were faced with the two papers from Sheffield, the second of which was the most worrying and turned out to be, although it was a perfectly proper publication and I knew Sir John Lilliman very well, we worked together for years in London, it turned out to be very misleading. I think it was 5 children, 2 of whom were only 2 and 5 years of age, who bravely received liver biopsies and who were shown to have significant persistent liver disease. We knew subsequently, of course, that the progression was 1% per year and that, as I said, spontaneous clearance occurred frequently in non-HIV patients and that cancer was less than 1% per year. And life expectancy subsequently shown to be reduced by only between 2 and 6 years. So there was a great deal of uncertainty, which it was our job, if you like, to transmit in information to patients without causing very unnecessary anxiety. And I don't mean that in a patronizing or patriarchal way. It's damaging to families to be told very uncertain information and to be hung the sword of Damocles above them for many years. And many years would be the case. The average age in the Sheffield adult cohort was around about 40 or something like that. So it was information that I hoped and assumed incorrectly had been transmitted largely over the years, sometimes more than a decade prior to my coming there. I did not spend enough time having made that assumption, reinforcing information with the legacy patients, if you like. And despite the fact that product information or patient information leaflets were present in the packaging from the late 1970s, Haemophilia Society leaflets became available. World Federation Hemophilia meetings were sponsored and patients attended very unusually. Peter Jones' book subsequently within the next year or so dealt with it. And all the other things like parent support groups, independent support groups, and a new clinic. And all of these were not adequate to adequately provide the information which I expect you wanted me to talk about. And I did not. I made assumptions that knowledge was better than it was, that information had been provided that had not been adequately provided. And I wasn't proactive enough in seeking information as opposed to doing what we were taught to do, which was just ask open questions. I'm sorry it's a very long-winded answer, but a very important question for me.
Professor Hann, thank you, and that addresses to some extent the questions I've been intending to ask you about the question of what information was and wasn't provided to patients at York Hill. Can I just take you back to the question of what your understanding was in the period 1983 to 1985, in particular in relation to non-A, non-B hepatitis? I understand what you say about uncertainty, and you've referred to various subsequent studies and what may have been learnt from them. We have seen, for example, materials from Dr. Kernoff from 1979 and 1980, I think, but certainly from 1979, characterising non-A, non-B hepatitis as being a serious disease with long-term consequences. Would you disagree with or would you have disagreed with that characterisation in the early 1980s?
To a certain extent, I would disagree, because we didn't know. If you added the words "could be" or something like that, I would entirely agree with it. What we didn't know, and I'm not being evasive really, we did not know the prevalence. You know, how do you communicate that? And the answer is inadequately, in my case. And I regret that. The fact is that, can I give you just two very brief examples of the problems that one faces as a paediatrician? I'm not asking anyone to feel sorry for me. The fact is that, you know, when it came to new variant CJD, what were we supposed, this was much later obviously, what were we supposed to tell people? We had no diagnostic test. We didn't know who could get it. We knew eventually that you could transmit it. We knew that similar diseases like Kuru could take 30 years to develop. What were we supposed to do? Tell people that maybe over the next 30 to 40 years you may get a debilitating, life-threatening, horrific neurological disease. The fact is that these are damaging psychological bits of information. And just as another quick example, it would be common in those days to say, go to the ward, and I can just give you one instance of many where, you know, you go to the ward, the registrar says, I'm a bit worried about this patient with leukemia or whatever. The potassium is 7, and I don't know why, and so on. And am I to go in and tell the parents that this is something that's incompatible with life, or do I explain to them, as I tried to, that we would sort this out as fast as possible? And in that circumstance, you can sort it out as fast as possible, but in this context of non-A, non-B hepatitis, etc., you could not. Basically, it's a hemolyzed blood sample. It's common in children with difficult blood samples. That's just one example of many where you could put your anxiety, dump it on a family, and expect them to cope with it without full and long explanation in a circumstance where you already know what the likely causes are, and you can be, to an extent, reassuring. And where you have some appropriate therapy, which did not, of course, was not, of course, the case with hepatitis C, as it, or non-A, non-B hepatitis in most cases. So my answer in the statement is incomplete, and I hope that explains it a bit better.
So would this be a fair understanding of your evidence? And please correct me if this is not fair or not correct. In your view, in the early 80s, it would have been correct to say that non-A, non-B hepatitis could be a serious disease with long-term consequences.
Yes.
It could.
That's true, but you know, how does one then define when it becomes a serious illness, and therefore you are hanging the sword of Damocles over somebody? Because for sure, I can tell you now, I am not going to be the doctor that does liver biopsies on children with haemophilia in that era. It's a dangerous procedure. It leads to deaths.
But can I leave aside for a moment the question? You're right, it logically follows as to what you might tell patients, and just think about what
Yes.
was understood, albeit with the uncertainties you've identified. You did understand, or you would have understood, that it could lead to chronic hepatitis and could lead to liver disease, but
Yes.
the prevalence of that was one of the areas of uncertainty. Is that a correct summary? I know it's only a summary of your evidence.
Yes, I agree. The prevalence and the definition were uncertain. The diagnosis, if you like.
You've referred to the Sheffield study in relation to children. You were, I think, from your earlier evidence, probably also aware of Professor Preston's Sheffield work. were you aware of what I think we've seen described in minutes of the UK HCDO's Hepatitis Working Party of the Sheffield Royal Free Collaborative Liver Biopsy study that was ongoing, I think, certainly in 1980?
I wasn't aware of it. I know that Peter Konoff told me, I think, or at least I found out somehow. I think he told me that they'd had one death related to a liver biopsy, which I wasn't aware of that study. Well, at least I can't remember being aware of it, sorry.
If we move then from the question of what your understanding was and your awareness of uncertainties to the question of what should have been said to patients, again, as I understand your...
Just before you go there, is one way of summing it up as to your knowledge after 1978, before 1983-84, that although you didn't know how prevalent it was, you knew there was a real risk that blood products might transfer hepatitis non-A, non-B.
Yes, I did know that.
And you knew there was a real risk that it might be serious.
Yes, but, you know, I'm sorry to keep rambling on about uncertainty.
I'm just looking for a simple way of expressing what you were saying.
No, I just like to add a slight caveat in that I'm not in any way criticising the Sheffield Children's study, which is completely valid, but it was extremely misleading. Yes, I was aware that it could be serious, yes.
If one then comes on to the question which you addressed a few minutes ago of what was said to and what should have been said to children, as I understand, to families at York Hill, as I understand your evidence, you are acknowledging that you didn't make sufficient proactive inquiries to establish what they had been told. Is that right?
Correct.
Is this right? Although information was available to patients in the form of Dr. Jones's book and the various other sources of information that you've referred to, there wasn't any proactive or systematic approach to ensuring that your patients received that information from the clinicians at York Hill?
Not proactively, no, other than the fact that I immediately recognised the need for a review clinic at which they were asked, do you have any other questions? And I did not spend enough time going through non-A, non-B hepatitis with people who've been around for years and attended on many occasions. That's my fault.
In terms of Dr. Jones's book, we can look at the texts if need be, but they are what they are. They say what they say.
Yeah.
The first book, which would have been the one available certainly in 1983, had been published in 1974 and deals only with Australia antigen hepatitis B.
That's correct.
The second edition was published sometime in 1984 and certainly does make some reference to non-A, non-B hepatitis and indeed to AIDS. Do you happen to know when in 1984 it was published?
I don't, but it should be easy enough to find that out from the ISBN.
I'm sure it will be, thank you. I just wanted to check.
I do remember ordering it as soon as it was available because I thought it was really good. And it probably made up for some of my own inadequacies.
Would you accept as a matter of principle that whilst there may be lots of other valuable resources that you can provide to patients, ultimately it's the obligation of the clinician to spell out to patients the risks and benefits of treatment rather than make assumptions that they might read materials elsewhere?
Yes, absolutely, and the buck stopped with me, not with Dr. Pettigrew.
I want to ask you then about your knowledge of AIDS, and in particular to ask you about a symposium you attended in June 1982, because you're the first of the oral witnesses that we've heard, I think, to make reference to that. This was something called the Second International Symposium on Infections in the Immunocompromised Host, held in Stirling in June of 1982. What was the nature of the event, and at whom was it, as far as you're concerned, predominantly aimed?
This was an incredibly valuable meeting, which was initially started off by the European Organization for Research into the Treatment of Cancer. In that era, and it was my particular area of expertise and specialization, deaths from the treatment as well as the disease itself, but particularly the treatment of leukemia, were far too high. And infections in the, as they called it, the immunocompromised host, in other words, usually cancer patients, leukemia patients, etc., of all ages, was a very important topic and a matter of governance, which I in particular took on board for initially for Manchester, but more widely thereafter. It was my particular area of expertise. So I attended it really for that reason, and it I won't easily forget it because I managed to become very ill during it with myocarditis and non-A, non-B hepatitis for the second time due to Coxsackie virus. And I only say that because my memory of it is very clear, despite the fact that it's so long ago. It was a very, very shocking meeting indeed, and it's impossible to exaggerate that. There was one talk in particular, and in those days it wasn't called AIDS or HIV or anything else, it was called GRID, which I think gives you an idea of the emphasis in those days, gay-related immunodeficiency disease. And to cut a very long story short, amongst this extremely frightening presentation and others, there was a list of persons who were affected, and at the very bottom of that list were either 2 or 3 persons with haemophilia, who I don't even know if it got into the final publication, but I remember it vividly. And so that was my first indication that there was a problem. Of course, one didn't know what the comorbidities were in those people, but there were lots and lots of theories as to the cause of it, and most people felt that it was multifactorial at the time.
I'm going to invite you to look at one of the papers from it, not least because we haven't looked at it at any of the hearings so far. Shomik, it's PRSE 302220, please. So this is the subsequent publication of materials relating to the symposium, which you attended in June 1982. We can see the date there being 1983. If yes. We could turn, please, Shomik, to page 18, I think it would be, of what you have. We can see there, in fact, this is entitled AIDS, Acquired Immunodeficiency Syndrome, yeah. Infection and neoplasia in homosexual men and intravenous drug addicts. And we can see the authors there. And I think you referred in your evidence to the Penrose Inquiry to some of those authors.
Yes.
It opens with, we're experiencing an alarming epidemic of an acquired immunodeficiency syndrome, AIDS, in certain cities in the US. It's affecting homosexual men, intravenous drug abusers of either sex, and Haitian refugees. And then if we go on, please, Shomik, to page 22. We look at the last paragraph on this page. We can see their reference to the mortality rate. Acquired immunodeficiency disease has a high mortality rate. 13 of 42 patients in our series have already died nationwide. Half of the patients have died. And then there's a description of what's said to be the typical course of the illness. And then if we go on 2 pages, please, Shomek. We can see if we look into the first main paragraph, about 6 lines down, the absence of treatment is referred to at that stage. Treatment of infections in these patients is hampered by the severity and apparent irreversibility of the immunodeficiency, and further details are given in relation to that. And then if we go to the next paragraph, please, Shomek. It says the etiology of this acquired immunodeficiency disease is not known, and then there's a discussion about cytomegalovirus and other hypotheses. And then at the bottom of the page, a role for an infectious agent is suggested by the fact that the disease occurs in people in whom infections are readily spread. Blood or body secretions would appear to be, we go to the next page, top of the next page, potential vehicles of infection, but since many people are exposed and only a few people develop clinical symptoms, factors such as differences in host resistance and inoculum size may be important. And then it goes on to discuss the particular position of patients with enlarged lymph glands. And then if we look at the very final paragraph on that page, Shomek, we can see there a discussion of the devastation of the illness. Those who take care of these patients realise how devastating this illness is. The early events need to be identified by prospective studies of high-risk groups and so on. So that's the written paper. You described in your evidence to Penrose, I think, about this being a bombshell, essentially, in terms of the nature and severity of this new disease. Is that right?
Yes, it was, yes.
And again, you told the Penrose Inquiry, we can look at the transcripts if you wish, but I hope these are accurate summaries, that you left the conference thinking that it was likely that this new disease was caused by a new viral agent and that it might possibly be relevant to patients with haemophilia. Is that fair?
Correct.
You, I guess, said again in your statement and evidence of the Penrose Inquiry that those who were in attendance at this conference were in particular those who were interested in leukemia, rather than those who were clotters, as I think you put it. Were there other haematologists present, as far as you can recall, who had the broader interest in, which included the care of people with bleeding disorders that you had?
No. Other haematologists, yes, but paediatric haematology is somewhat different, as I expect you would notice by now, but we had to wear several hats in those eras, whereas haemophilia treaters tended to be, in the main or totally, haemophilia treaters, and they would not have attended this conference. But there were a large, it was the best by far conference of its nature in the world. It was attended by many microbiologists and infectious disease doctors. And there were, I think, even people from the SNBTS there who gave a talk. And that can be checked, but I'm pretty sure that's correct. So it wouldn't have been something that haemophilia doctors would necessarily have been aware of because of this meeting, but it was part of the burgeoning knowledge that began to explode at that time.
Is it something that should have been shared with haemophilia doctors? I don't mean necessarily by you, Professor Hann, but you've referred more generally in your statement and indeed your evidence this morning to issues about communication, information sharing, availability of information. How would the news of this, from this conference, how could it have been disseminated more widely to those treating haemophiliacs?
I think that's quite difficult because it was, it's not exactly a niche area by any means, but it was produced, in those days it was quite common to produce a book of a meeting. Unless you bought that book or disseminated that book, you wouldn't know about it. But I'm sure you've found that there were a whole series of publications. I would expect haemophilia doctors to be aware of the general medical press, the Lancet, the New England Journal, etc., etc. And I don't recall how many there were, but there were many publications. It was a very, very hot topic from then onwards, and in many areas. I mean, haemophilia treaters don't just read publications about haemophilia. I mean, they read the general hematology literature, and they would be expected to keep up with the general literature, such as the New England Journal Lancet.
You referred to having been referenced to 2 or 3 cases with haemophiliacs you remember from the conference, and we know that it was in only the following month, July 1982, that the CDC in its MMWR publication drew international attention to those cases. Was the MMWR a publication that you had access to at the time?
No, it wasn't. It's a daily reading for me now in transfusion, but it certainly wasn't widely read in that era. It required it. It was like a newsletter almost. It still is, but it's very widely read throughout the world now. But in that era, it certainly was not.
Now, you were at this time, mid-1982, still at the Royal Free, although I don't know whether you were still working with Dr. Kernoff and Professor Tuddenham at that stage.
No, I was there I'm almost certain in the early part of 1980. And although it was a joined up department, I wasn't working with him or Professor Tuddenham for the previous nearly 2 years.
Do you recall any discussion at the Royal Free in the latter half of 1982 about this new illness of AIDS?
Oh yes, there was. I can't remember any specific details, but there were a lot of, the Royal Free was very well set up for all sorts of things, including lectures and education and seminars and all the rest of it, to which all of the haematology department would attend. And I can't remember exactly when, but certainly during that period there would have been discussion and presentations on the subject.
You've referred to the New England Journal of Medicine, and we know that there was an editorial in the New England Journal of Medicine in January of 1983 by Jane DeForge, which looked at AIDS and haemophilia.
Yes.
Is that something you think you would have read at the time?
Yes, I think so, although I don't know, I did not know of her particularly. I don't think she was a haemophilia doctor, but doesn't negate the findings.
And the Lancet, at the end of January 1983, again, there was an article in the Lancet about AIDS and haemophilia. Would the Lancet also have been on your general reading list at the time?
Oh, definitely, yes.
I want to pick up what was being discussed amongst haemophilia clinicians in January 1983 about AIDS, by reference to the minutes of a meeting that you weren't at, Professor, and we wouldn't have expected you to have seen, but it's a useful summary rather than looking at lots of different documents of a state of knowledge. It's PRSE 302647, please, Seamus. It's a document I think you're aware of now. So it's notes of a meeting with Immuno at London Airport, 24th of January. It's January 1983. And if we go to the 4th page, please, Seamus. We can see from the list of attendees that at this meeting there were multiple leading haemophilia centre directors, not just reference centre directors, but others as well.
Yes.
Including in terms of Scottish presence, Dr. Ludlam. If we go to the previous page, and we pick it up in the last 2 paragraphs on that page, please, Seamus. Professor, this is in the context of a discussion at this meeting in London with Dr. Krask summarising the current position in relation to AIDS. You'll see there, the minutes record, or the notes record, it being said that up to the 10th of December, some 800 people had been reported as suffering from AIDS. There was a 45% mortality. 10 haemophiliacs in the US have been affected, 5 have died. The youngest was age 7. all cases have had prolonged treatment with factor VIII, but there's no specific implication of one particular product or batch. And then it goes on to refer to 3 cases involving blood and blood product transmission in non-bleeding disorder patients, so transfusion of platelets, one of which was a 20-month-old child who had developed a possible AIDS state. And that was a case that had been reported in the MMWRs in December of 1982, Professor. If we just go to the top of the next page, we can see then there's reference to incubation period appears to be 6 months to 2 years. In the UK, only 1 or 2 cases so far have been reported. And then there's a discussion about protocols in the US and reference then to the New England Journal of Medicine. Now, as I say, I'll check with you, Professor, but I have assumed, is this correct, that you weren't aware of this meeting at the time?
Could you just tell me the date again?
24th of January 1983, so just as you moved to York Hill.
No, I have subsequently been made aware of the meeting, but I knew nothing about it at the time, or its outcome.
I've taken you to it, Professor, just, as I say, as a convenient summary of information that was being shared, at least amongst a number of haemophilia clinicians at the time. Given what's set out here, which was, I think, not knowledge unique to those attending the meeting, but had been fairly widely reported, would you agree with this, that certainly by the end of January 1983, by which time you've had the New England Journal and the Lancet publications, it should have been understood that the likeliest cause of haemophiliacs being infected, although the numbers were still relatively small, was the use of blood products?
There was a slight glitch in the sound there, sorry. What date by, did you say?
By the end of January 1983.
Yes, I think, again, we didn't know what the prevalence was likely to be, but yes, we would have been aware by this stage that it had become clear that haemophilia persons were affected.
So haemophiliacs were at risk. You didn't know necessarily to the extent of that risk, yes, and at risk of being infected with something which was known to have a very high mortality rate.
That very high mortality rate is, of course, in people who have other risk factors. So we didn't know what the mortality rate was going to be, but it was frightening enough as it was, yes.
And I think, again, appreciating you didn't know exactly what was being said at this meeting, but we see it being reported by Dr. Krask that 5 of the 10 haemophiliac cases reported in the States, the patient had died.
Yeah.
I want to then take you to March 1983 to a document that you should have received at the time. It's a communication from Dr. Krask. It's HCDO 40/517_001, please, Shomik. So we can see this is a letter dated the 22nd of March 1983. Dear Director, our understanding is that it was sent to every haemophilia centre director. It refers to recent discussions in the Hepatitis Working Party and a meeting of reference centre directors and the circulation of various enclosed papers, the aim of which was to set up a system for the reporting of possible cases of AIDS. If we look in the second paragraph, we can see that criteria for reporting are set out. And in the third paragraph, Dr. Krask says we strongly urge you to collaborate in reporting cases of this syndrome. And if we look at the next page, we can see it's from Dr. Krask, Dr. Ritzer and Professor Bloom. I should perhaps draw attention to the top of the page where they say any developments of significance will be circulated to you before then, that's before the next AGM in October, as soon as information is available. Do you have any recollection of receiving this letter, Professor Hann?
I don't have any specific recollection, but as I've said in my statement, I hope that we were asked I don't know if you're asking about whether we responded to this, but there were a lot of requests for information to be sent to centralized organizations and other organizations, etc. And all of us, Dr. Pettigrew, myself, and others, were very concerned about disseminating any information other than truly I can't think of the word, anonymized, information. If anonymized information was requested from a proper organization, then we would have complied with that.
Well, you were being asked here, as all directors were, to effectively report to Dr. Krask any suspected cases of AIDS. Do you recall whether you did so?
No, we didn't have any suspected cases of AIDS.
But would you agree that the reason you're being asked to do this by UK HCGO at this time, and when I say you, I mean all directors, is because of the recognition that it was likely that AIDS was transmissible by blood products? That was the very reason for asking directors to look out for possible cases.
Well, the main reason, yes, is the answer to that. But the main reason is, in fact, to know about the prevalence,
yes,
the natural history. That we needed to know how to manage these patients.
The thrust of your evidence to the Penrose Inquiry was that it was really in the second half of 1983 that it hit you and other directors that AIDS was going to be a significant issue. Why did you put it as the second half of 1983 rather than early in 1983?
Yeah, I think there's, from my point of view, there's been a little bit of conflation of HIV infection with AIDS, which I think is important to be clear about. We didn't know the natural history, as I've just said. We needed to know that in order to be able to inform people and to know how to manage, how to follow up people, how to use prophylaxis in children and so on. So the answer is the big clue came in May of 1983, and I think you may have already heard about all that. Montagnier's description. There was a fair bit of not skepticism, but lack of understanding as to whether this was really the agent at the time, and so on. So as far as the virus was concerned, my own view, and that of many others, was that he'd cracked it and he got the Nobel Prize and all that, but it wasn't really for another year until we were absolutely sure 100% that was causing the problem. It was a transmissible disease. It was going into haemophilia persons who'd been treated, and but we did not know. It appeared that it was different in haemophilia. I expect you've had other people tell you all this, so I'll be brief. But it wasn't the same in haemophilia. We didn't have any patients who were wasting. We didn't have any patients with Kaposi sarcoma. In fact, it was very uncommon in haemophilia because it was due. I mean, AIDS is not caused by one virus. It was due to the HHV8 virus. Subsequently, we knew, and so it was multifactorial. It was always thought that it was multifactorial, and it turned out that it was. So I'm sorry, a long-winded answer. We knew that it was transmissible. We knew that HIV had entered, sadly, the haemophilia population. We did not know yet the natural history of the disease or its true pathogenesis, and we had no therapy.
What was the point in time, doing the best that you can, Professor, that you thought the parents of children with haemophilia had the right to know that the treatment that they were giving their child might transmit a fatal disease?
I prefer to use a different tense, if possible, might have transmitted. There was little evidence subsequently. I mean, I'm not answering this very well. I wasn't aware, and I'm still not aware, as to whether any of the product that was used from 1983 onwards transmitted HIV. I think that my attitude at the time was that it was becoming more and more likely that HIV had been transmitted, and that at some stage during 1983, especially after the publications and the finding of the virus, controversial though it was and continued to be, that discussions should begin at that time. There was obviously common knowledge at this time, unfortunately reflected in the pariah status that many haemophilia families found themselves in, that HIV was a problem in the haemophilia population. It would have been unconscionable in a way that haemophilia families did not know that. Certainly during the latter part of 1983, and again, we discussed it as appropriate and passed on what information we could.
So is this right, that it's not until after May 1983 that you would have thought it incumbent upon you to explain issues relating to risks of AIDS to families?
No, that's not quite true. If during 1983, I can't remember all the dates, I'm sorry, when it was in the media and all that, there was a welter of information, a lot of it very unhelpful in the media. The families were extremely well aware of it and would ask questions about it. But it's very tough sometimes to give information in the face of lots of lack of knowledge. That would be passed on as it was available, and was very often in the media as soon as it was. I mean, Montagnier's findings were in the media before I knew it. It's not a question of keeping it from them or being lacking in transparency. We had nothing to hide. It was a question of how to provide adequate information that wasn't simply giving them massive anxiety in a situation where they may well not have had it as a problem.
Would you accept, I think, going back to a question, I think an answer you gave a few minutes ago, that patients, it's not for patients to try and understand risks from the basis of what might be reported in the Mail on Sunday or the Observer, or indeed in a Haemophilia Society bulletin, which may or may not represent the risks in a way that a clinician thinks is accurate. It's for the clinician to explain their understanding, imperfect though it might be at a given time, to the patient.
Yes, although that sounds easier than it is. But you're absolutely right. I would entirely agree with you, which is why we set up parent groups and they set up their own groups, and we had a social worker. It's a process in family communication. It's not just the almighty doctor coming in and pontificating on something. It's a process over a period of time, and a development of trust and an ability for people to ask you questions when you don't know exactly what they know or what they want to know, no matter how open your questions are. So yes, we did use the Haemophilia Society. We used their leaflets, we used their meetings, we encouraged people to go to the World Federation. I'm not going to run through it all again, but it's not just, and obviously the reason I set up the clinic was so that that facility was there, and we didn't just rely on ad hoc visits.
In the course of 1983 and 1984, how often would the clinics be clinics that you were taking, and the conversations you were having as distinct from Dr. Pettigrew and Sister Murphy?
We mainly did it together. There was a shortage of rooms apart from anything else. Dr. Pettigrew and I. Dr. Sister Murphy would quite often not be able to attend because she had other duties. We didn't have a dedicated nurse or a dedicated social worker or a dedicated psychologist. All of those were available and were quite good, but intermittent to an extent. As to answer your question precisely, I can't, but the clinics were set up initially monthly, but were frequently more often than that, and I would attend them at least twice a month and sometimes on a weekly basis during the period when we were informing those families that had not had an opportunity to discuss it already in the daycare centre with Dr. Pettigrew.
Dr. Pettigrew's evidence yesterday was that there was no policy as such about the provision of information in relation to aids to patients or their parents. Would you accept that?
Well, there was no written policy, but the policy is the policy of paediatrics. It's an ethos rather than a policy, if you like. It's a question of an open door policy, first and foremost, transparency and honesty, and to be as full and detailed as you can be. We discussed it on numerous occasions. I didn't write down a policy because it depended on the family and their availability. It was a very difficult decision which we did not get in, and it's my fault, we did not get entirely right with regard to the process as opposed to the policy, if you like, as to how best to contact people, how best to see them, how best to get through to them all of the information that we had and was essential on all sorts of things like universal precautions, etc. So no, there wasn't a policy, but it was perfect. It was a question of multiple discussions between us, which we agreed between us, but it was my responsibility.
It might be said that the thrust of Dr. Pettigrew's evidence was that rather than proactively contacting patients to discuss risks of AIDS with them, the approach was reactive. If questions or concerns were expressed by parents, they were then addressed, and there might then be a dialogue and conversation that would ensue. Is that your recollection?
It depends what you mean. Do you mean before or after we got the results?
I'm talking about the period before you got the results, so 83, 84.
The answer to your question then is correct.
That brings me then to the question about the results and the process by which you discovered that a number of patients, former and present, at York Hill were tested positive for HTLV3. We heard yesterday from Dr. Pettigrew, her recollection, that you received a letter from Dr. Follett, which set out results that hadn't positively been sought, as far as she was aware, by the Haemophilia service. What's your recollection, please?
Yes, I mean, as I say, we met on a daily basis, and my recollection is that I have no recollection of requesting these results, and I'd just like to enlarge upon that slightly. If I had requested it, it's almost certain that she would have known. I didn't plan my own furrow with regard to this. As it was essential that we had this information. Within blood transfusion services to this very day, we still struggle about pre-test counselling. It was, I seem to be saying every 5 minutes that it was inadequate. Pre-test counselling was not the order of the day. We did know that samples, I did know, personally, I did know that samples for virology were stored. This was not an absolute routine. I had, as I've said to you before, my interest was in infection in the immunocompromised patient, and so I'd done a lot of virology follow-up of such patients, and I knew that to an extent, where the samples were available and where they were adequate, which they often weren't, for children because they were large samples. We knew that they were there. We knew that there was a lot of development going on with regard to testing. All virology testing, no virology testing is perfect. There is no such thing as a virology test which is absolutely specific and accurate and sensitive. So there were real problems in the initial phase of development of the serology for HIV with regard to false positives and false negatives. And it would have been incredibly unhelpful to pass on information in the face of that. We still have problems in blood transfusion services. For instance, if you go as a blood donor today, you will be asked to sign a form that says, I consent to my blood being tested for anything you like for the next 30 years or more. It's essential that we can do that for the sake of the donors and the recipients. So the pre-council testing did not happen adequately. I don't recall asking for the results to be there, but for reasons which I can explain, it was essential that we had that, and it was unconscionable to me at the time that a family would not wish to know about the health and well-being of their own children, and for reasons that I can explain.
You said pre-test counselling was not done adequately. Does it not follow from your evidence that there was no pre-test counselling at all because the samples were tested without any knowledge of parents?
That may be the case, although we had discussed with them, and there was a lot of information, again in the media and in the Haemophilia Society, for the absolute need. There was an absolute need at the very first moment, as there has been for every pandemic, for tests that tell you that somebody has it or not. The assumption, which has been shown by psychologists and ethicists and others subsequently, with hindsight, we should have spent more time on that and done it better.
Where was Dr.
I should have.
Where was Dr. Follett based?
Goodness, the virology reference lab. I'm sorry, I don't know where it was.
Was that at Rock Hill, or it wasn't at the Royal? It wasn't at York Hill, is that right? Or it was?
No. It was the virus reference laboratory. I think it was at Rock Hill.
In terms of trying to put a date on when this process was undertaken, because we don't have the letter that Dr. Pettigrew recalls you receiving from Dr. Follett and then telling her about. We know that in December of 1984, Professor Ludlam received the information, the information about the patients infected in Edinburgh from SNBTS product was made public in the form of newspaper articles in December of 1984, and Professor Ludlam told us about a meeting that took place on the 19th of December 1984 in Edinburgh. Dr. Pettigrew's recollection is that she was off on maternity leave in the first part of 1985 and returned in May, and that it was in May of 1985 that the discussion took place with you about the results from Dr. Follett, and then the dissemination of those results. And there's at least one, there's a letter from May, which is from Dr. Pettigrew to a doctor in Inverness with a particular result. Are you able to assist at all with when this testing process might have been undertaken?
I wish I could, and I say that for a couple of reasons. First of all, I don't know whether you can get more information from Professor Lowe. He may have used the same source for the testing. I don't know. Looking at the results, there was one test in particular which was confusing, because my memory, which is, I'm afraid, not precise at all, was that we heard about this at the end of 1984 and the beginning of 1985. Amongst those tests, there is, you probably noticed, a result from May of 1985. Now, I can't be certain about that. You can make up hypotheses, but those hypotheses depend on that being that sample, that one sample, with no previous samples on that person being a retrospectively tested sample, whereas it may not have been. I could only tell that if I had the letter from Dr. Follett. My memory of the letter from Dr. Follett was that there were between 8 and 10 York Hill patients at the time who were infected. I'm sorry, I can't be more precise than that. You could make a theory that the results came in May of 1985. That doesn't, that isn't my memory, but my memory is far from precise.
It's right to note, and you've referred to it in your statement, I think, that there is a meeting on the 29th of November 1984 attended by Dr. Gibson, in which Dr. Gibson reports 5 out of 10 patients testing positive for HTLV3, which would suggest that, if correct, that there had been some testing by the end of November of 1984. Do you recall whether testing was undertaken in 2 stages or undertaken by anyone other than Dr. Follett?
The initial testing was done in 1 stage only. We did not contact, I knew Professor Tedder very well, but we did not do anything through UCL or anything like that, or the Royal Infirmary or anybody else. But obviously, one of the issues here was, is this a reliable test? It's vital, crucial for all sorts of reasons, obviously, to know that it is, and therefore it was necessary to contact the families expeditiously and pass on the information that we had as well as we could, and to retest and to carry out a further confirmatory test, which I believe was Western blot testing at the time. And as it turned out, I think that it's true to say that all of them were confirmed.
The process for telling at least the current patients or their families at York Hill, as described by Dr. Pettigrew, was to await their next attendance at the centre, whether it was a spontaneous attendance, as it were, because something had arisen, or their next scheduled clinic attendance. And Dr. Pettigrew's recollection was that wouldn't have been more than a few weeks. I think she said 3 to 4 weeks, perhaps, typically. What can you recall about the process and your decision as to how patients should be told?
Yes, I remember it quite well because it was a very difficult decision. To be honest with you, neither of us knew the best way to do this. I was quite sure in my own mind, and we both were, that sending out a letter to people initially was, with any information other than a clinic appointment, was not appropriate. They were already all very worried indeed. We hoped that the majority, and I think the majority did attend because they were mainly people requiring frequent visits to the daycare centre, that would be the method. And the final thing that we agreed was that we would make sure that this was done within a 6-week period maximum, and preferably before, for several reasons. First of all, because we needed to pass on the information, because we needed to be sure that universal precautions were re-emphasized, and that we gave information such that the families were aware of, for instance, pneumocystis cerevisiae, because they might well require prophylaxis or immediate treatment. So that was what we agreed, and that's what we tried to put in order.
The effect of doing it that way, as Dr. Pettigrew explained yesterday, was that because it was often one parent only who brought the patient in, typically the boy's mother, the mother would be receiving the news of her son's infection with HTLV3 without the father or other family members being there. Do you have any reflection or observation to make in relation to that?
Yes, it's far from ideal. On the balance, I think in retrospect, it would have been better to bring them up to clinic visits over a period of a couple of weeks through a letter saying something along the lines, we need to discuss your overall care and results and such like, or in some way that wasn't going to frighten. I mean, getting a letter saying you've got an appointment in 2 or 3 weeks to talk about something devastating is not something that is easy to live with, obviously. But with the benefit of hindsight, certainly, and probably I should have realised. There was at least one case subsequently where this caused unnecessary suffering. We always had an open door policy such that they could come back the same day, the next day, at any time. Usually Monday to Friday, but I was there every weekend as well. So we could have dealt with it in that way, such that there was not a long delay in passing on that information, but it did cause unnecessary suffering.
Professor Hann, I think the answer to this may be obvious from the evidence you've already given, but it's a question I've been asked to seek clarification on. The samples that were stored in the virology lab and presumably used for testing by Dr. Follett, those would have been samples stored on a named patient basis, presumably, because the information was then coming back to you to disseminate.
Yes, they were, yes. But obviously we have to rely on virologists not to disseminate information, which they didn't, in my experience.
The issue of when the patients did or may have seroconverted was obviously looked at for the purposes of the Penrose Inquiry. I'm not going to go back over what was said at the Penrose Inquiry or in the Penrose report, but did you have any involvement with that work?
No, it was instigated by, I think, Dr. Chalmers subsequently. It was a very difficult thing to do because of the sometimes patchy information.
Do you recall any discussion between you and Dr. Pettigrew, or indeed with parents, about whether to tell the boys themselves, the patients themselves, of their infection, and if so, how and when?
Yes, I'd spent at least 7 years in paediatrics and training as a general paediatrician before this time. The day-to-day job of a paediatrician includes talking to children, usually with their parents, obviously, but sometimes their older ones in particular are there on their own. So it's part of one's job. Now, with regard to imparting information, which could be extremely frightening, especially to very young children, even as a fully trained paediatrician, this is not something one should ever take on lightly. It requires specific training, specific counselling training, and one of the things that I did at York Hill was to bring in the social worker who had such training, and in Great Ormond Street, and I mean training with children. And I'm very pleased, by the way, that the inquiry is looking specifically at the needs and requirements of children during that period. The nurses that we were able to appoint were expert counsellors. We had access to expert psychology, child psychologists and child paediatric input. So the answer is a very simple one, really, that the opportunity there for a paediatrician to speak to a child is always there, and I certainly made clear throughout my career, I hope, that that was always available. But it's a process again. If you take leukemia, for instance, one of the most important people is the play therapist, because they have specific training in dealing with, say, 4-year-old children or 3-year-olds or whatever it might be. How do you impart the type of information that you need to pass on to a young child who has a life-threatening disease. And the life-threatening diseases of leukemia could mean, for instance, acute myeloid leukemia at the time, 70% of them died. It requires sometimes psychology input, and it certainly requires expert assistance. It's not something one should ever do willy-nilly, but it is there. It's not something that, again, I really must emphasize, there was no question of me being the senior person there. I was responsible, but we worked as a team. And the team is there and is available. And to a certain extent, like the social worker, is independent of me and is available to talk to the family and the children. Now, final point. Throughout my career, I looked after hundreds of children with leukemia. There was always an opportunity to speak to children, and we always had one mantra, which was really, first of all, whatever you tell them has to be the truth, not necessarily the whole unvarnished truth if it's just frightening, but it really has to be given in that way. And the second point I'd make is that given that, and having proactively throughout my career said that, very few families actually want me in particular as the frightening doctor or whatever to talk to the children. Maybe that's a reflection on me, but it's actually really a reflection on the fact that the others are much more experienced and skilled than me. You don't take that sort of thing with anything other than real seriousness. Children are perfectly capable, and I've seen it, of becoming seriously depressed and extremely anxious, and that can be a long-term issue.
Did you have parents asking, on being given this devastating information, how it had happened that the treatment given by the NHS to their son had infected their son with this devastating disease? And if so, how did you answer, as far as you can recall?
I think I was asked this question. I think a lot of people in Scotland, anyway, in my experience, it was different in England because there was a lot more use of commercial concentrates, were wanting to blame pharma, basically, and the fact that we had never, and also the fact that the health service had never provided enough. And, I've been going back to self-sufficiency, if you like, but the fact was that they largely blamed the commercial concentrates, although I can't remember the numbers, but there's at least one that was probably infected with cryo and probably one or so that was affected by SNBTS product. The answer is that, and you've heard from others, I think, that I just had to say to them, if we took the Hippocratic Oath, we've in some ways broken it. Primum non nocere is the relevant part of the oath, first do no harm, and we had done harm unintentionally, and that probably there was very little different that we could have done about it. That the inquiry may disagree with that latter statement, and I fully accept that, but that was my transmitted information at the time.
So I note the time, and I'm going to move on to a slightly different topic after lunch.
Well, we'll take a break in that case for an hour, bring us back at 2 o'clock. So time for lunch, Professor.
Thank you.
2 o'clock.